My name is Hsieh. Today I'm going to talk about surgical considerations and treatment for spine tumors. It's an area that I'm passionate about. It's an area that I believe it's relatively underserved in neurosurgery as well as spine surgery today. So spine tumors come from a variety of sources. Metastatic tumors are secondary tumors that come from other primary sites. Primary spine tumors are tumors that arise either from the bone or the soft tissue surrounding the spine itself. The important thing to note is that we should not lump all spine tumors together as a single group. The biology of these tumors are very different, and the treatment is really based on the differences in the different type of tumors. So the first thing I'm going to talk about is metastatic spine tumors. These are the most common type you'll see. Metastatic spine tumors really comes from cancer diagnosis, and you have about a million new cancer diagnoses a year. About 10 to 20% of them are going to have spine involvement. In fact, many of them will initially present with spine symptoms as their cancer diagnosis. And that's because spine is the most common site of musculoskeletal metastasis. When you look at the sources, the most common tumors that causes metastatic spine tumors are your most common cancers: lung cancer, breast cancer, prostate cancer, renal cell cancer, as well as melanoma. The other thing that we're facing is that there are actually increasing number of long-term survivors. Medical oncologists are doing a great job keeping patients alive, but they're not cured the disease. As a result, we have a higher burden of patients who may be symptomatic for metastatic spine tumors that may require treatments. So treatment for metastatic spine tumor is not dependent on surgery. Surgery is itself not the primary treatment for most metastatic spine tumors. Most of the time, you're dependent on medical treatment such as systemic chemotherapy or targeted molecular therapy that we have today. We're also dependent on radiation therapy to provide local tumor control in cases that are going to respond to radiation and do not need surgery. Pain management is an option for patients who have presentation of mainly back pain. More and more, we're doing more of these interventional treatments that are bridges between the traditional medical treatment like radiofrequency ablation, laser interstitial therapy, cryotherapy, and even vertebroplasty and kyphoplasty. These are treatments that are less invasive than your traditional surgery, but can offer local tumor control or can offer local stabilization of the spine itself. Surgery, in my opinion, is a critical component of treatment for a very selected group of patients. These are usually patients who are later in their disease and have neurological symptoms, or they have intractable pain from spinal instability. The surgery is performed to improve the neurological symptoms or neurological function, and also to provide pain relief from restabilizing the structural integrity of the spine. So treatment of metastatic spine tumor has been argued by many generations and decades to be ineffective with surgery, and that's because traditional surgery is really a laminectomy that does not address the location of the tumor. It also does not address any spinal instability that often comes from involvement in metastatic spine disease. In addition, with surgery, you introduce wound complications, infections, wound breakdown, and even mortality rate that's not seen with systemic or chemotherapy or radiation therapy. And because of this, many have argued that surgery is ineffective. And in addition, there's also concern about the added cost of surgery. Ultimately, surgery does not improve the long-term survivor outcome for most patients with metastatic spine tumors, so these arguments are relatively valid depending on the patient's symptoms and disease status. I do think that we're still at a stage where we got to consider surgery for a selective group of patients we talked about. Metastatic spine tumors are not well treated when you're treating it with chemotherapy or medical treatment when there's epidural core compression already. Medical treatment also can address severe structural instability of the spine. You may be able to address the pain, but you have to address the structural stability of the spine to protect the spinal cord, to make sure that their patients aren't at risk for spinal cord or neurological injury. Most people would agree that there are specific benefits with surgery that comes from the direct and immediate decompression of the spinal cord, and that's why whenever patients have acute neurological dysfunctions or acute neurological problems, they will call the surgical team to evaluate the patient for surgery. In addition, surgery is the only treatment that can truly restore the structural stability of the spine in cases of gross instability. So just because patients may benefit from surgery doesn't mean all patients should have surgery. Patients should be considered surgery only if they have reasonable risk, and that at the minimum should have a reasonable life expectancy from their cancers from metastatic disease. And generally, arbitrarily, most people believe that 3 to 6 months is the minimum of survival that these patients should be considered for surgery. Obviously, we take into account their previous response to medical treatment. We also take into account the extent and the sites of the metastasis. If patients have, a large burden of disease in their lungs or in their livers that result in end organ disease or end organ failures, these patients are not likely to do well and survive from their surgical recovery. Functional status is actually a very important prognosticator for life expectancy. Patients who are dependent on others for their day-to-day care are generally have a shorter and poor life expectancy compared to patients who are independent in their functions. And besides their cancer, many patients, particularly in the elderly group, will have medical comorbidities such as cardiovascular diseases, pulmonary diseases that need to be taken into account as part of the surgical morbidity. Then you have cancers that are very radio-resistant. They're not effective to be treated by radiation. So cancers such as renal cell melanoma, if there's symptoms of epidural core compression, even before they're at a severe neurological compromise, should be considered for surgery. So in general, I think that surgery should be considered whenever there are epidural core compressions that are symptomatic and or spinal instability that patients have either pain or at risk for neurological injury. And these patients, as long as they're surgical candidates, should be considered for surgery. All right, so what's to be expected for the results of surgery? In these patients, the goal is to preserve neurological function or restore any neurological injury. The goal is also to provide pain relief from restoring the structural integrity of the spine. So in these patients, what you gain is the improvement of function and quality of life because they're able to ambulate and improve in their pain function. There are studies that also show significant improved local tumor control. There are also studies that shows improvement in survival in some of these cases. Now, in these cases of improvement in survival, it's not because surgery improves the overall burden of the metastatic disease. What it's doing is improving the systemic function of the patient so that patients are able to live independently and relatively pain-free so that they can avoid some of the other medical complications that can lead to morbidity and mortality. Overall, it's important to focus on the goal of treatment for metastatic spine disease as in palliation only. The goal is not to improve long-term survival. It's important to point out the study by Patrick et al., which is really the most definitive study in looking at metastatic spine disease treatment with surgery followed by radiation, comparing to radiation. So it's important to make a distinction that this is not a study that compares surgery with radiation only. This is a study that compares surgery with radiation afterwards, comparing to radiation alone. In this randomized control study, which is considered to be the best level of experience or best level of evidence in scientific clinical studies, the endpoint of the study that they measured was ability to walk. So this was a very easily measurable outcome. And then they also looked at other secondary outcomes that includes urinary incontinence, muscle strength, functional status. All these are related to other measures of neurological preservation or function. And they also look at survival time. Now, one of the most important distinction factor about this study is that the aim of the surgery is to provide immediate circumferential decompression of the spinal cord as well as stabilization of the spinal column. So this is more of a modern concept that was not the goal for surgery for metastatic spine tumor for many decades in the 20th century. So when you look at the results of the study, there's clearly difference between the surgical group where patients were treated with surgery followed by radiation compared to radiation alone. You can see that after their treatment, about 84% of the patients in the surgical group retained their ability to ambulate, whereas in the radiation group, it was only 57%. If you look at the details more closely, in the patients that are able to retain their ability to walk, the surgical patient actually are able to retain the ability to walk for 122 days in the median days. And that's actually pretty much how long these patients survive after their treatment. On the other hand, if you look at the radiation therapy, even if they maintain the ability to walk after surgery, the median days of that maintenance of function is only about 13 days, so less than 2 weeks. So many of these patients actually deteriorate subsequently following the initial recovery from their radiation. So overall, in terms of treatment for metastatic spine tumor, it's clear that surgery is not the primary treatment modality. Whenever you can, you want to improve tumor local control, and this can be achieved through medical treatments such as systemic therapy or radiation therapy, and even less invasive treatments such as radiofrequency ablation or laser therapy. It's also important to maintain spinal stability when you can, and there are medications like bisphosphonate that can prevent progression of pathological fractures. Bracings can help to reduce some of the pain and prevent further fractures. And then vertebral kyphoplasty can be used to augment a fracture that is mildly or moderately fractured without gross instability. I think the key to improving these patients' outcome in terms of treatment of metastatic spine disease is to identify symptomatic patients early and identify those patients at risk for neurological injury or progressive epidural disease earlier. These patients generally will have progressive pain or progressive motor sensory loss, what we call myelopathy, when there's dysfunction of the spine compression or spine injury, if you will. Now, more and more, we're going toward more minimally-invasive spine techniques, and I don't have time to go into the details of this. This has been very widely practiced in degenerative spine surgery. We're taking more of these techniques to achieve very similar outcomes in terms of surgical goals, but it's done in a much less invasive technique, so there's overall reduction in blood loss and pain. I think the critical elements to improve patient outcome for a metastatic spine tumor is to provide multidisciplinary care team or delivery system for metastatic spine tumor patients. In the past, most practices operate in silos between the medical oncology, the radiation, and the surgical community. And we only really work with each other when there are progression of the disease to a point where it may require surgery acutely urgently, and thus many of these patients present in the emergency room or in an acute setting. On the other hand, when you have a multidisciplinary care team that addresses many of these patients' needs for metastatic spine tumor early from a medical oncology or radiation oncology or surgical perspective, patients are going to be identified much quicker when they're at risk for neurological compromise or spinal instability that is going to require a sooner intervention. So when I deal with spine tumors in general, I think about this principle of maximizing oncological outcome and minimizing treatment morbidity. Before I talk about primary spine tumors, I want to finish up on talking about metastatic tumors and our treatment algorithm. And that is in metastatic spine disease, our goal is palliation. So we want to minimize the treatment morbidity by improving our infection rate, improving our blood loss rate, and improving our post-operative neurological or medical complication rates. And we do this by doing the smallest operation possible for these patients, and many of which are being performed due minimally invasive techniques when we can. But these patients are best identified early if they're going to have a less invasive treatment rather than when they present acutely with paralysis for days at presentation. Now moving on to an area of a little more subspecialization in spine tumor treatment are the primary spine tumors. Primary spine tumor treatments are very different. Our goal is to maximize oncological outcome, and we might accept a little bit higher treatment morbidity as long as it's not permanently disabling or at risk for mortality. So primary spine tumors arise from the bone or the tissues within the immediate area surrounding the spine, if you will. So for most common primary spine tumors that are benign are the vertebral hemangiomas. Rarely do these need treatment, whether it's medical or surgical treatment. On the other hand, chordoma, which is really the most common malignant primary spine tumors, these patients are extremely challenging to treat, and we'll talk a little bit more detail in the coming slides. We also deal with a fair amount of intradural tumors that are within the spinal canal and inside the dural sac. Most commonly, you have neurosurgery tumors such as schwannoma, neurofibroma, and then you have meningioma. These are commonly treated, and in our center, we treat these pretty much through minimal-invasive techniques only and are able to get these patients home within 24 to 48 hours in most cases. Intramedullary tumors are more rare tumors, but they're tumors that include ependymoma, astrocytoma, or other glial tumors. These are much more rare in presentation, but generally is part of a spectrum of tumor we treat in a complex spine tumor program. So I'm going to focus on the next portion of my talk on primary spine tumors. So the extent of surgery has been shown in primary spine tumors to correlate with improvement in disease-free and overall survival. And actually, in some cases, surgery can be curative, particularly in most of the benign tumors, in fact. Medical treatment and radiation therapy, on the other hand, generally have more limited efficacy in many of these primary tumors. And because of this, surgery is a big portion of the consideration whenever you're addressing primary spine tumors. So I'm going to talk about chordoma. Chordoma is a relatively rare tumor, but it is actually the most common primary malignant spine tumors in adults. It's an area of my interest and expertise here at USC. Chordomas can occur in the sacrum, most commonly in the spine, but they also occur in the rest of the mobile spines, including the cervical, thoracic, and lumbar spine. They also occur in the skull base at the clivus, as many of you may be aware. These chordomas are slow growing and they look relatively benign on the microscopic slide. However, they're actually quite locally invasive and have a propensity for recurrence, and they can actually metastasize, and ultimately they're life-threatening to the patients that have chordomas. Unfortunately, there are no effective chemo or radiation therapy available for chordoma, despite our vast experience in treating chordoma over the years. The extent of surgery has really been shown to best correlate with the disease-free survival as well as overall survival in these patients with chordoma. The goal of the treatment for chordoma is maximizing our surgical resection of the tumor without leaving residual microscopic diseases behind. So in the skull base, this is a little bit tough given that most skull-based surgeries would have to be done intralesionally, and by definition, you will leave microscopic disease behind. On the other hand, in spine, we have a little more latitude because we don't have significant or critical neurological structure at times near the tumor, and we have a little more latitude to resect and remove some of the tissues that could improve our ability to treat these tumors. So in chordoma cases, we follow a classification scheme and treatment scheme that many would use in orthopedic long bone primary tumor surgery. In these cases, our goal is to aim for en bloc excisions at the minimum. En bloc just means that you remove tumor as a whole. That itself is not quite enough. We actually need to remove a rim of normal tissue surrounding the tumor when we can. That's called a wide tumor en bloc excision, when we remove at least 1 to 2 millimeters of normal tissue surrounding the tumor. And what that actually does is avoid microscopic and satellite lesions surrounding the tumor. In many cases, however, in the spine, we're only able to achieve what we call marginal tumor resection, and that's because tumor resections can be achieved through dissection of the pseudocapsule or the capsule of the tumor, but it puts the patient at risk for having some microsatellite or skipped lesions that could be left behind. Nevertheless, that is the best that we can do in many of these cases when it involves critical nerves or structures such as vessels or the nerve roots. So this is an example of what we could do with modern technology and treatment for chordoma. This is a patient with a large C7 to T3 chordoma. This is the primary site of the tumor and the first diagnosis. Patient underwent biopsy and confirmed this to be a chordoma. If you look at the imaging critically, this tumor is already up against the spinal cord, severe spinal cord compression, clearly likely involving the dura as well as the surrounding nerve root. And because of this, we're only able to achieve marginal resection at best and know that we're going to leave microsatellite or skip lesions behind. As a result, we prescribe what we call neoadjuvant proton radiation to minimize that risk, and then perform an en bloc excision with marginal en bloc excision in a staged fashion with reconstruction of his spinal column with a long segment cervical thoracic fusion. And this is the result of the surgery. Where you can see we can remove the tumor specimen as a whole without spilling the tumor, and we subsequently reconstruct his spine, connecting his neck back up to the rest of his spine through a complex instrumentation scheme and fusion. And this patient is now 4 years out and has been working full-time since his recovery of surgery and continues to live disease-free. So as daunting as high risk of these procedures can be, these are extremely gratifying procedures because you can really make a difference in keeping these patients alive longer than your traditional treatment algorithm. So we have actually published a number of studies on this, and this is one of our initial studies when I was at Johns Hopkins, where we show that with en bloc excision, if you don't achieve wire marginal en bloc excision, your survival benefits are not necessarily there even with an en bloc excision. So in all these cases, we attempted en bloc, but there were some cases we actually enter into the tumor inadvertently, identified either at the time of surgery or by the pathologist. And what we were able to show in the study is that those that were able to achieve wire marginal en bloc excision have a significant longer life survival. They reach a median survival of almost 6 years, whereas those that have contaminant intralesional excision, the median disease-free survival was only about 2 years. So significant disease-free survival is achieved whenever we do these wire marginal en bloc excisions. Similar results are also seen when we treat cervical spine chordomas. These are actually high risk because of the involvement of important cervical nerve roots that are important for arm function as well as the vertebral artery. Even in these cases, they are a bit more complex and risky. What we saw was that complications rates may be higher, but the survival benefits in terms of disease-free survival was similar to the sacral chordoma that is seen with the extent of our en bloc excision. So in summary, treatment of spine tumors can be fairly complex as tumors come from a wide variety of sources. They could be metastatic from many sources or primary from the bone or primary from the soft tissues surrounding the bone. For surgical treatment of spine metastatic tumors, the goal is palliation in nature. So our goal is to really preserve or improve these patients from their neurological compromise and improve their neurological function. We want to improve their quality of life and pain. And ultimately, the patient selection is critical because only patients that can live long enough and have minimal surgical risk are going to benefit from the results of metastatic spine tumor surgery. On the other hand, primary spine tumors are very different. We can make a huge difference in improving disease-free and overall survival in many of these cases. So for chordomas and similarly malignant primary spine tumors, our goal is to achieve the most aggressive radical excision that is safe and with relatively acceptable risk. And when we're able to achieve en bloc excisions with wide or marginal en bloc excisions, there are significant improvement in disease-free and overall survival in these cases. Thank you very much for your attention. I also want to acknowledge and thank the colleagues that have worked me along with me through the years in the spine tumor program, our medical oncologists as well as our radiation oncologists and our neuroradiologists are a critical part of our multidisciplinary spine tumor program. Thank you.